All right, let's jump right into one of the absolute highest stakes areas in medical coding, myocardial infarction. We all know that accurate MI coding isn't just about protecting revenue integrity. It's really about painting a true, precise clinical picture of a patient's cardiovascular health. The guidelines we have to navigate for acute, subsequent, and historical infarctions, they are complex, for sure, and they depend entirely on your provider documenting the actual clinical pathophysiology. So let's dive into this explainer and master these guidelines together. But before we even crack open the ICD-10-CM manual, we've got to get our clinical foundation rock solid. Simply put, a myocardial infarction is defined by irreversible cell death or necrosis of the heart muscle. And this happens because of prolonged ischemia, meaning that tissue is literally starved of oxygen-rich blood. If a provider documents ischemia, but there's no irreversible cell death, well, we are going down a completely different coding pathway. It's that specific, irreversible necrosis that makes it a true MI. So to know exactly where we're going, we have to look at the neighborhood we're working in. Ischemic heart disease lives in categories I-20 through I-25. And notice how carefully structured this whole section is. We start with I-20 for angina pectoris, then move right into I-21 and I-22 for acute and subsequent infarctions. We pick up the complications in I-23, and then we round the whole thing out with other acute and chronic conditions in I-24 and I-25. Understanding this flow is absolutely crucial because it helps you instantly spot whether a diagnosis belongs to the active infarction family or if it's just a chronic condition.
All right, moving right along to Section 1, MI classifications, types 1 through 4.
Okay, the most common distinction you're going to face every day is type 1 versus type 2. Now, a type 1 MI, that is your classic heart attack. It's a spontaneous event caused by a primary coronary issue. Think of a plaque rupture directly blocking the blood flow. A type 2 MI, on the other hand, is completely different. It's secondary to an ischemic imbalance. The coronary arteries might actually be clear of any acute rupture, but something else, like severe anemia, a drop in blood pressure, or a coronary vasospasm, creates this massive mismatch between oxygen supply and demand, and that mismatch is what leads to the cell necrosis we just talked about. Now, while types 1 and 2 definitely steal the spotlight, you absolutely need to recognize the rest of the family. Type 3 is a unique one. It's an MI that results in a fatal event before we even get a chance to draw biomarkers, like troponin. Then we get into the procedure-related infarctions. Type 4A is related to a percutaneous coronary intervention, or PCI. Type 4B is specifically tied to stent thrombosis. And Type 4C, that's an MI due to restenosis of 50% or more. Each of these types tells a totally different clinical story.
Let's put this into practice with a real-world scenario. Imagine you've got a patient admitted with a severe acute anterolateral wall STEMI. They get treated, maybe transferred for an angioplasty, and they go home. But exactly 1 week later, they are readmitted with severe chest pains, and the doctor diagnoses a completely new inferior wall MI. How are we coding this readmission?
Well, here is the exact coding logic. Since that new infarction happened within 4 weeks of the initial one, we have to grab a code from category I-22. So your principal diagnosis is I-22.1. Subsequent ST elevation myocardial infarction of the inferior wall. But wait, we don't stop there. We still have to report the original MI as a secondary diagnosis to give the full clinical context. So we bring in I-21.09 for that anterolateral wall STEMI. Basically, the I-22 code acts as a pointer to the new event, and the I-21 code anchors the history of what happened in the past 4 weeks. All right, round 2. Let's look at a scenario that literally trips up coders all the time. Your provider documents a type 2 NSTEMI due to demand ischemia. How exactly should you code this? Take a quick second to think about your type 2 guidelines. The answer is right there in code I21.A1 for myocardial infarction type 2. And you really need to pay attention to the strict instruction here regarding demand ischemia. You absolutely do not assign code I24.8 when a type 2 MI is present. Just don't do it. Plus, even if the provider specifically calls the type 2 MI an NSTEMI or a STEMI, the guidelines are crystal clear that codes I21.01 through I21.4 are strictly reserved for type 1 infarctions. For type 2, you always use I21.A1, and you've got to sequence the underlying cause, like the anemia or the hypotension, first if it's known. Let's kick this up a notch and combine these concepts into a master-level edge case. What code do we assign when a patient comes back in with a brand new type 2 MI occurring within that critical 4-week window of a previous type 1 or type 2 MI?
We just established that the 4-week window usually triggers that I-22 category, right? But does it apply here?
Nope, it doesn't apply at all. You assign only code I21.A1. According to the ICD-10-CM official guidelines, you never assign code I22 for subsequent MIs unless they are type 1 or unspecified. If you look closely, there's a very specific excludes one note right under category I22 that explicitly tells us a subsequent type 2 MI is assigned code I21.A1, not I22. Honestly, this is a massive compliance trap, so always remember a subsequent type 2 still just equals I21.A1.
Okay, let's wrap things up with Section 2, Edge Cases. We'll be looking at old MI and non-ischemic injury.
First up is old MI, which is coded as I25.2. This one is super interesting because it essentially acts as a history code, but it hangs out in the cardiovascular chapter instead with the Z codes. The golden rule you need to follow here is that you should never assign it if current active ischemic heart disease is present, and even then, only bring this code onto the claim as an additional diagnosis when that historical infarction is actually clinically significant to the current episode of care. Please, don't just blindly code it because you saw it sitting in a copied and pasted problem list.
And lastly, let's talk about myocardial injury. This is completely distinct from an infarction. For a non-traumatic, non-ischemic myocardial injury, you're going to use code I5A. The absolute most critical guideline here is sequencing. The underlying cause has to be sequenced first, assuming it's known and applicable. You see, these injuries are usually driven by systemic issues, not primary coronary ischemia. We're talking causes like severe sepsis, heart failure, myocarditis, or maybe a pulmonary embolism. So always look for that underlying driver and get it sequenced first.
And that brings us to the end of our deep dive today. Whether you're dealing with a classic type 1 plaque rupture, a demand-driven type 2, or you're trying to track a subsequent event right in the middle of that tricky 4-week window, the rule of thumb is this: track the clinical types carefully and apply the guidelines precisely. The physiological cause literally dictates your entire path through the ICD-10-CM manual. But I want to leave you with this question. If your provider's documentation doesn't explicitly give you that underlying cause, are you querying them, or are you just leaving quality data and revenue on the table? Thank you so much for joining me for this explainer, and remember, decode healthcare with Harshal.